Hey everyone, welcome back to House Healthcare. So we have with us Elena Barabee, thank you, for Green Mountain Care Board. And I thought it would be good for us to review what the Green Mountain Care Board put together about the 2023 hospital actuals. Just to give us a sense of what's happening in our hospital system of care. No action. We're not taking any action on this. It's just educational. So I'm going to turn it over to Elaine.
Great. Thank you for having me. And so this can be conversational. So if you have questions along the way, please feel free to stop me. So first I'll start with some health system trends, kind of background, big picture. Then I'll go into the 2023 actuals and then kind of end with what's coming up next. And there are some slides that you've seen now probably numerous times on the board, so I won't spend time there. But here's kind of where we start. So we know that healthcare spending in the United States is much higher than other countries. If you look at the per capita rate of growth of healthcare spending, Vermont is even higher than the national average. So this is quite concerning. And that translates into, how we pay for healthcare. It translates to premiums, out-of-pocket costs. It affects Vermonters, it affects businesses, and as you've heard, it affects your school budgets, which we'll talk about. But this is showing the marketplace premium averages for a silver plan. So we see it in our regulatory purview. We know that there are a lot of great things and reasons why it would be higher in Vermont. So we have community benefit, among other things. We do have an aging population. These things do kind of contribute to that.
Can you explain what a community benefit is?
Sure. It's community rating. So, where everyone is kind of considered the same. There's not different kind of premiums and different methodologies for different folks, right? So we're all kind of working from the same.
Where in other states, there could potentially be an age rating. So there'd be a lower cost for younger people and a higher cost potentially for older people. We don't do that here. Yes, right.
Besides age rating, are there other demographic factors that are used in other states to discriminate and give people different?
I can come back with that. I don't have that off the top of my head.
It's not that important.
Okay.
It was just the thing that I thought of when you mentioned age.
Yeah.
Okay.
Okay. Great.
What's stunning is that ours almost is in the neighborhood of doubling.
Yeah.
The others are both flat.
Right. Yeah. And so the growth is what's right. So there's a reason why it might be higher, but the growth is what's concerning.
Yeah, it might be a little higher, but
Yeah.
that is,
Quite a bit higher.
Do we know why it's growing?
yeah,
Well,
what is causing that?
We can dig into that.
Okay.
Yes. And so this is just marketplace. So there are, lots of other insurance markets. But this growth
This is Vermont Health Exchange.
yes. So, but this trend is kind of everywhere. So as we mentioned, it's really everywhere. It affects our property taxes. It affects our businesses. It affects the benefits that businesses can offer their employees. It's the reason why many school budgets are not passing. It's a real challenge. And so one of our major contributors, you talked about pharmaceutical spending. That's certainly a large chunk of it, but hospital spending makes up, approximately half of our healthcare spending. Hospitals are very important. They are very expensive. And so, but we need, to think about, how we're spending our healthcare dollars, how it's growing, what those dollars are going to. And to be totally transparent, I believe this hospital spending includes pharmaceuticals and other kinds of spending. So it's not, it's a little bit of everything.
And can I just make a statement that is based on nothing other than what we talk about in this room? So you might have data that supports or doesn't support it, but we often talk about how we are trying to change what's happening in the community and provide community supports because to alleviate people going to the emergency rooms or being sicker once they get to the hospital. And then obviously we have the concern with people boarding in hospitals. So
Right. So there are a lot of reasons why this might be higher. And prior auth is another bill you guys are thinking about, exactly that same, rationale. And thinking about whether that's going to contribute to higher spending or not really depends on where people are getting their care. People are not getting, they're having to go through this process, they end up in the ED instead. That's substantially more expensive than if they could have been seen in perhaps another setting. So I just want to remind folks, it's not, our higher levels of spending, and we do spend more on hospital care, I think, than other states, again, is partially because we are an aging population, but if you look relative to New England, we're still kind of an outlier. But we are low utilizers. So this graph shows hospital admissions per 1,000 residents at the state level. Vermont is that green on the left. So we're really towards the tail end. Yeah, go ahead.
Yeah, keep going. I will interrupt you when you just keep going.
Yes. And so the United States is right in the middle of the national average.
All right, so I'm gonna stop you there. Maury.
On that slide, so that doesn't include hospital care that's provided on an outpatient basis?
No.
Procedures?
Right. So we do know that there's, and I think it would be great to have a chart like this. Unfortunately, these national comparative data are really kind of intensive to find and to develop, but we do know that there is a trend to shift to outpatient, but that trend is really happening everywhere. So I wouldn't expect, it'd be great analysis to do. Is it happening more in Vermont than other states? Yeah. Thank you.
All right, and then
So
Elizabeth.
follow up on that so that I know what we're talking. These are inpatient,
Inpatient. Yeah.
inpatient only.
Yeah.
Okay,
Yeah.
thank you.
Alyssa.
The slide before the pie chart. So when we're talking about hospitals,
No, the pie chart.
Oh, sorry, the slide book. I think it's the slide booklet. Okay.
we're talking about everything.
That goes through.
So,
Yes.
you've got 6% per physicians or 9, I can't, 6.
Six, yes, sorry, it's very small.
So that doesn't include hospital employed physicians.
So physicians is, so the hospital could include some hospital employed physicians, I
And
believe.
that would be in the hospital,
Yes, in the hospital. So there's a
So-
subset.
all outpatient.
I should double check that actually.
Everything.
This is I think physicians, I'll have to double check where employed physicians.
I'm just trying to think of like if a primary care practice is owned by the hospital,
Yep.
affiliated with the hospital, which bucket?
Which
is it
bucket?
going into?
My hunch is that it's going to be in the hospital. Yeah. But we'll have to look at that. We're redoing our expenditure analysis methodology to try to clarify these kinds of things. So those are really, we'd love to kind of have these clean lines around kinds of services, but it's very tricky. Is it a primary care delivering primary care services, or is it a specialist delivering primary care services? It gets very complicated. Or, and what is physician? It's more than just primary care. It could also be specialty care. So these categories are meaningful and we should be thoughtful about how it's a very good question. Right. So we'll get into, I just wanted to give you some background of where we are and then kind of dig into FY23. But first I wanted to talk about kind of what we approved, what the board approved in fiscal year 23. So this was following the pandemic. 2022 was one of the worst years in a long time for hospitals. It's kind of all of the COVID relief funding dried up. We had inflation, we had a lot of extra costs in the system. And then 2023, this was our kind of recovery year. There were we have granted net patient revenue growth of 8.5%. Net patient revenue is the total kind of reimbursements received by a hospital for delivering services to patients. So there are a number of ways hospitals can kind of collect, reasons they can collect money, but the main one is, delivering care. So we allowed that to grow by 8.5%, which is quite substantial compared to prior years where we were really trying to keep it around 3.5%. And the commercial charge growth, so this is what kind of correlates to price increases, we allowed to increase by 10.5%. So that was really because of concerns around inflation and staffing and making sure that we could maintain a robust healthcare system.
Remember, a lot of our hospitals have been using travelers extensively.
Yes, this was a big year. So, where have we come since 2023? this chart, there's a lot going on here, so I'll try to spend some time. But this is really looking at our actuals over time, so relative to 2017. So if you look at the 2023 chart bar, that is what we ended up spending at the end of 23. And you can see 24 budget and then the 25, potential based on the guidance we've just approved trended forward. Some of these other lines are interesting. So the blue line at the bottom is if we grew the net patient revenue, so total patient expenditures for hospital care by inflation, that's where we would kind of end up with the blue line. So as you'll notice, it's quite a bit lower. We know that we had COVID and it wasn't kind of rational. So, we expect it to be higher. The orange dotted line is if we grew from 2017 at 3.5%. So the all-payer model, our last kind of major reform model, said, we want to bring healthcare spending in line with economic growth. So we should really try to stay within 3.5 to 4.3%. So that orange line is the 3.5. That green dotted line just above it is the 4.3%. And so if you look to the right, there's some dollar figures there. If we would have stayed at 3.5% since 2017, and we had achieved that goal that we set out, we would have saved or spent less than $500 million on hospital care. If we would have, gone to the higher level, it's still kind of $300 million. Just to give you a sense of kind of where we are, we're in a much higher rate of growth. So over time, since 2017, the compound growth of our total patient spend has been around 6%.
The target was 3.5 to
3.5 to 4. Yeah. And that's fluctuated year to year, and so that green line is really operating expense. So you can see, it's not that we're just raking in the dough and our hospitals are flush with cash. We're spending more money. So those are.
What is causing that green line to?
It's a very good question. So, we have a lot of infrastructure that requires maintenance. We have a lot of staff. We have, staffing challenges. We have to rely on contracted staff, which are more expensive than if we hire local folks. Pharmaceutical spending is very high.
So what's the biggest cost driver of that? Is it the travelers?
I'm sorry.
Is it the travelers?
I think it's staffing overall. I think, and this is one thing in the facilities overall. And then I think, these are it's the cost of maintaining a hospital. And then I think thinking about, how efficient you are, there's not a great measure of efficiency, but, some of our smaller hospitals aren't able to serve as many and we need hospitals there and they may be less efficient. Sometimes we have access challenges and so we may not be able to serve as many patients, but we might raise prices. So there's a lot going on here to unpack. So it's a combination. It depends which part of the state you're looking at. So part of our work, which I'll get to at the end, is really about community engagement and trying to understand what's going on in a particular community to try to understand what the opportunities are to improve health and efficiency and affordability for a community and providing recommendations back to the community to do that.
And another question.
Yes.
In the hospital, is the staff, the cost of staff, is that your biggest?
It's your biggest, yes.
Is that because of
And technology, yeah, yes.
okay, unions and travelers together?
I don't know. I don't know how we compare.
I mean, that's
Yeah,
a real jump.
it's a big jump.
Okay, we have a lot of questions. Alyssa, Mari, Bobby.
I'm just wondering, prior to.
And can I, before you say that, I also want to remember, although Green Mountain Care Board regulates the hospital system, Lena does not work for a hospital.
No.
So I just want to,
hospitals.
so I just want to remember, lay that out here.
I'm just wondering, prior to 2017, were we keeping growth artificially low as a measure of how well we were doing, and then it caught up to us?
don't think so.
Or were we constraining growth?
We were constraining growth. I think we were also, it was a different time, right? Like I think inflation has been a real challenge, not just for Vermont, but for a lot of states. A lot of states have seen in the more recent years significant growth with, given the workforce shortages and after COVID particularly. But I think, I think it's hard to say if it was, I don't know what you mean by artificially.
I mean, if I can compare it with what's kind of happening with a lot of school budgets is, through COVID, there were all sorts of other funds. And so the growth went, but there were funds to take the place, and then all of a sudden the funds dry up and.
That's fair for, I think, from 2020. So I think 2020, after COVID, they had a lot of extra funding, right? And so then we spent it, right? And now we're at a much different place. And I think part of the challenge with nonprofits is like, what's the right level of spending, right? Because you don't have a profit at the end. It's a zero bottom line. So you need to take in what you spend, right?
All right.
I want to bring context to the staffing question. Staffing is always the biggest line item or one of the biggest line items in any hospital budget. So that is nothing new. And as someone who has worked in the hospital system my whole career, I can tell you that hospitals have in general been unsafely staffed as far as nurses go for many years. And so if any of that increase in operating expenses related to hospitals and staffing has to do with more staff and safer staffing, I am experiencing that now in my own hospital. I'm experiencing the safest staffing I've ever had in my career. And so that's a plus. And because of work done at the federal level, the agencies, the travel agencies for contracted staff like nurses are not able to charge as much. So the cost of travel and the pay to travel nurses has gone down. And I credit the staffing also the increase in safe staffing. I credit our unions for helping that equation. So it's not that unions are costing us more. In the long run, safe staffing saves money. But you're going to see, yes, and nurses have been historically undervalued and underpaid. So we're doing a little bit of catch up. And that may be part of the operating expenses, but I can tell you it's made a huge difference, at least for the folks that I work with.
Absolutely.
And we don't have as many travelers either.
It's coming down.
It is coming down.
It is coming down.
Yeah. Bobby?
In some places, yeah.
I know you don't have a role regulating hospitals in other states like New Hampshire, but because of where I live, Dartmouth Hitchcock is always a big part of the
Right.
picture. And I was wondering if that ever, for the sake of comparison, if that number's been thrown in there.
So we'll get to that.
Oh, okay.
Yes, so that is the other half of the state. So we don't regulate Dartmouth, but some of their affiliated hospitals are in Vermont, and they are major, hospital for Vermonters. So it's important to look at.
Do we regulate their affiliates in Vermont though?
Yes,
Okay, just.
yes, if they're located in Vermont, they're regulated. So we kind of took apart the growth, some of the questions raised earlier, what are the drivers? But there is certainly a difference between UVM, our health network growth, and non-UVM health network growth. So if you look over this period of time, the growth of the UVM health network was compared to the rest of the system was about 40% versus 24%. So that is an important thing to note. That is from 2019 of 2023. And then back to your question. So looking at some comparative prices, this is one of those main contributors to some of the differences. So we talk about cost, but there is also kind of price discrimination that could happen because we do not rate set in our state. If you look at the green bars are for the University of Vermont Health Network. The blue bars are the affiliates and Dartmouth Hitchcock. Each hospital on the left is a star that has a star. It's a critical access hospital. And what this chart is showing you are prices relative to Medicare. So if you, across the bottom, you'll see it goes from 0 to 3 or 3.5. One at that bar one, where most of the critical access hospitals are hovering around, means you are charging commercial prices that are 100% of Medicare, so right around Medicare. Some of the other bars, if you get close to 3, so a lot of those green ones, means that you're charging 300% or more of Medicare for prices on average for services.
I'm sorry, if they're hovering around 1, they're not paying Medicare, they're paying 100% or
The
double,
commercial price, no, are they're around that, so it's the same price, so you're
same price.
around the same price as Medicare, right?
0 is not,
0 mean, so there's no one at 0, because that would mean you'd get no reimbursement from your commercial coverage. But the thing to note about critical access is they get Medicare, they get cost plus reimbursement, so it's not directly comparable to some of these other hospitals.
Is there a reason that not all of the hospitals are on this chart?
Yeah,
It would be a lot. I'm happy to do that analysis for you. The data exists. We're just trying to get apples to apples in terms of health systems comparison. These are our 2 largest health systems that Vermonters are served, but we.
Okay, now I get it. I was like, why is the London Hospital on here? Right. Got it.
Where's the
looking
London
for like.
hospital?
New Hampshire. So they're looking at who's connected to Dartmouth and
It's gonna-
who's connected to UVM.
Yes.
Yeah.
That's why
It's
CB
really hard to get apples to apples. So, this is a starting place, but yeah.
I'm confused with what this is telling me.
Yes.
I'm not getting what.
So, so this is saying that if I go to UVM Health Network for care, the price that I would pay as a commercial patient would be 300% of what Medicare charges. right?
Medicare,
Medicare.
okay.
But if I go to London Hospital, I'm going to be paying what Medicare is charging.
Okay. Why is there that variance?
It could be a lot
What
of.
causes it?
Right. So I think there are different theories, right? So you've heard the cost shift, but you've also heard market consolidation. So, hospitals can set prices. They're supposed to set prices within the cap that we provide. But, there's a lot of things that happen between that. Could be cost, my costs are increasing, so it translates to higher prices, but it could also just be I can negotiate higher prices. So, yes.
And this is, based on this is totally wrong. I always thought that the hospitals are, it's not.
No.
Hospitals
That you
are.
could go, I could go to Rutland
Why?
Regional and the price would be the same as it would.
No, that's it. We tried to do that a long time ago.
Yeah, I didn't realize it wasn't the case. Okay, learn something new every day.
Okay, yes, a lot of variation. Okay. And we know that there's also to, continue talking about variation, there's variation in wait times too. So just because you're paying more doesn't necessarily mean you have lower wait times or higher access. So the green kind of circled the 2 that were in the previous slide. So Dartmouth is around 45 days for wait times. And then UVM Health Network, and this was from the Secret Shopper.
Yeah, I want to note, this is from February of 2022.
Yes.
And there was also some concerns about how the data was collected. So I just want to put that out there as well. Okay.
You may not know this, but you might be able to find out someday down the road. How do these wait times compare to healthcare systems in countries that have universal healthcare?
It's all over the place. I mean, I think there's a lot of variation even in countries that have universal healthcare, but I think that's, it's a good question.
Would you say that it's a myth that wait times are longer in the countries that have universal healthcare than in capitalist healthcare systems?
I think it depends. I think there are
That's
lots
the
of
myth we
variables.
hear is like, oh, if we
Yeah.
have universal healthcare, there's going to
I
be
don't think
long
it's-
wait times.
I don't think it's a 1-for-1.
Okay.
And I think different countries do it differently, and there's lots of ways to implement universal healthcare that will look, very different. So it has its own.
And you might be able to, you might have to wait in a country that has universal healthcare, but if you have private insurance, that speeds up the process for you in those countries.
Or if you pay out of pocket.
Well, that's what I mean. Yeah.
It depends on the service and the kind of care you're looking for.
In Vermont and the United States, if people are paying out of pocket versus using health insurance, is there any evidence that you're aware of that they can purchase care quicker because they're paying more out of pocket?
I don't know that individual providers, I mean, perhaps, I don't know that I have evidence of that individual providers discriminate, but are certainly providers that don't accept certain kinds of payments like Medicaid. And in those cases, it'd be harder for Medicaid patients to get access to care, and they may be seeing longer wait times.
And there are also, I mean, I don't know if you see this in Vermont, but I am aware of healthcare providers who are employed by one person, like Madonna has like a doctor, there's people who have, and they get that care like this, yeah, so.
We could all be Madonna.
Yes.
All right, let's keep going.
And I won't
Botox.
spend too much time here, but part of our hospital budget process is really looking at, how are we spending our dollars? It's really not there's not like a formula to say this hospital is efficient and doing all the right things. It's really complicated, and populations have different needs and their hospitals might look different. But really making sure that dollars are going to direct patient care as much as possible. So one thing we looked at last year was proportion of administrative to clinical salaries. And so you'll see, like from this UVM Health example, they were around 24.36%. This is their number. Our original source had it around 31%, but it still kept them kind of in the 71st percentile amongst peer academic medical centers. So this is just an example of the kinds of under the hood analyses that we do in our process.
So does that mean that 60% or so is patient facing?
Yes. Yeah, or six, yeah, or
I mean, whatever the
70,
yeah.
yeah, the other. Yep. So, as I mentioned a couple slides ago, now we've had some great conversation. There were substantial kind of increases in the FY23 process, but, there were, if you'll see, this chart is looking at days cash on hand. So it's how much cash a hospital needs to cover its operating expenses. It's cash-based operating expenses, and you'll see that hospitals are actually in a worse position this in 2023 than they were previously. And so having, for example, 48.8 days cash on hand, so it's Southwestern Vermont, means you have 48 days left of cash to cover your expenses, and then you usually run out.
Do you know what the standard is? Like, where do most hospitals feel comfortable with
Yes,
many days?
it's a really challenging thing. So you'll see some of like S&P, for example, has upwards of 200. But that means that you're tying that cash in the system. So it's really kind of your risk tolerance. Is it 3 months? Is it 6 months? What is it? I think, we know that some of the hospitals are currently challenged with the claims-based processing, the Change Healthcare issues, and they have been getting advances other ways, but there is a reason as risk increases that you might want to have more cash, but we really should be careful that we're not over reserving and kind of doubling down and hoarding cash either. Yeah.
Leslie, and then
So do you notice a trend about which hospitals have the least cash on hand? Is there any common thread?
Yeah, I think, it's some of the one, I think that's a good question. I don't know that we've done an analysis. If I just look at them, it's typically kind of like your smaller hospitals, your hospitals that have less wiggle room, your hospitals that have lower payer mixes, right? More challenging payer mixes, so.
Yeah, I mean, when you look at Springfield Hospital in 19, when before it went bankrupt, there was 16 days cash on hand. I mean, that was scary.
Yes,
And wonderful that it's up to 71, but it's still pretty low
very well,
compared to others.
right.
I'm still back on slide 20.
Sure.
Yeah. Is there a national trend, or what's the average for that? To just compare 24% to, is there a general?
So I think 50th percentile was around 15%, but I would have to look at that. Yeah,
How we compare now?
yeah.
I also just want to remind people about the University of Vermont Medical Center that although, yes, we need to compare them as an academic medical college as well, center, they're also a community hospital for Chittenden County. So they are like every other hospital in that is where several of us on this committee go potentially for their healthcare.
So I just think that's important to keep that in mind.
That's true for Dartmouth too, I think, right?
I don't know the answer to
I
that.
think the answer is yes. Yeah. So that's the apples to apples, that they both do both.
Right. I would question the per capita that's using it as a community.
That's interesting.
Good point.
Okay. So we talked about the days cash on hand. You'll notice that Copley was around 42.5, so it's the lowest one on this chart. And they came in this year for a mid-year budget request. So I wanted to flag that for you. So this is FY24 process. So in the FY24 process, we granted 8% increase. They requested an additional 12.7%. So it would put them over 20% commercial rate increase for this year. Given their really low projected operating margin of almost -3, and the days cash on hand of 42, and that their prices were low, like some of the lowest in the state, and they couldn't make up the volume. So like small hospitals don't really have kind of floodgates of demand the same way that larger hospitals in more populated areas have. So they, put them in a challenging spot. So the board approved a 7% mid-year increase for Copley Hospital. So that took them up to 15%. So it should get them kind of higher, closer to some of their peer hospitals. The net impact for the system, though, because Copley's so small, was only around 3%, estimated to be around 3% based on NPR. There's probably more sophisticated ways of modeling that.
Where is that hospital?
It's my hospital.
Where's
We've
that?
been on.
Oh,
I know. Where is it?
gee.
It's in Morrisville.
Morrisville.
Yeah.
So how do, how do commercial insurers respond to these requests?
So I think that remains to be seen. I think now it's up to them to go back and negotiate those rates. And then, they can't go up, but they could be, at or
That's the
below.
next step, is that they say, okay, we got this approval, therefore now we can talk to you.
Yes. And then part of the challenge here with, granting commercial rates, you can't just continue plugging all the gaps in all the hospitals. This is a real challenge. We have a declining commercial population. So in 2012, it was around 57% of Vermonters were commercially insured. That's down to 49% as of 2021. And I really hope there's money in the budget to continue. This is from the Household Health Insurance Survey, which is such a great resource. So, I think that, but it highlights a lot of these things. It also talks about uninsured rates and who's getting care, who's not getting care. So, it does show that our uninsured is down, but like the population who's really plugging the budgets at the end of the day is shrinking, which means that anything we pass on to them is only growing that much more.
Which could go back to that first chart where there was a big gap between our Vermont Health Exchange premiums for silver
Right.
versus
Part of it is just numbers, yeah. So what's next? So I think, I just wanted to remind folks, I don't know if you've had much of this, but if we just established the hospital budget guidance last month for the fiscal year 25, which will begin in October. And so we set targets for net patient revenue growth of 3.5% over last year's budget, commercial price growth of 3.4% over last year's budget. And we really want to see some positive operating margins. So these are the benchmarks against which we'll evaluate hospital budgets. If they're able to meet all three, we say, all right, great, we're not worried about you. You're going to, you won't impact premiums exponentially. But if you're over that, then we really need to understand why, right? And it's on hospitals to justify their budget requests. It's not saying you can't go over, it's just saying if you have to go over, we need to know why. And we hope that you'll be having a plan for improving affordability, quality, and access to care.
Art and then Brian.
Yeah, how does the hospital improve affordability? I mean, what do you do? Someone comes in for care, you give them care. Well, actually, I've noticed some things that could be done with my own experience, but
Right.
I wonder what, you may not know, and I understand.
No,
you
I
gotta
think
work
this
in a
is a
hospital.
great question. I mean, I think there's certainly a lot, and it depends on which hospital and where you
Yeah,
are
yeah.
and what you are doing and what your community needs, and is it,
Do we charge the CEO with this? Does somebody say, or does the board say, CEOs, I want you to do this?
so
Is that ever said?
we put 4 hospitals on performance improvement plans, asking how they're going to manage costs this past year.
Okay.
Yes. And so we'll receive updates in this year's hospital budget process. So, I mean, it is up to CEOs. These are all independent, private hospitals. So the board cannot make hospitals change their operations in that way. But, there is other work and other levers we have as a state or as a board or as the Agency of Human Services that can really change how hospitals deliver care. So we've talked about payment reform, so changing how we pay hospitals. Right now, hospitals are subsidizing some of their essential services with higher margin services. So we're spending a lot delivering, care that we may not, we could be better serving patients in the community setting or elsewhere. We may not be, as a state, leveraging all of our resources in the most efficient way, but that would require kind of communities to work together.
How about unpaid debt? Does that figure into this and how much does it figure? We had a session,
Sorry, what was the question?
unpaid debt,
We,
how much?
Uncompensated care,
uncompensated care,
Okay.
yes.
bad debt and uncompensated
Sorry,
care.
I was like, we can look at the balance sheets next
No, no,
time.
no, Somebody comes in and they never pay.
Yeah, so that's certainly part of it. Part of that gets kind of mediated through tax relief through hospitals, but I think, some of it becomes funded through commercials, so there's a lot of different
Yeah, right.
ways of doing it.
Leslie?
I'm just wondering about, and you may not know this, the role of the hospital boards, because we mentioned the CEO, but I think they have, the overarching community involved. So how does that all interact?
Right, no, you're right. There are boards, and I think there's a lot of variance across boards and,
Depends on the hospital.
yeah.
Because it depends who they hire in terms of, creativity, and I'm just thinking about it in my own.
Right.
Very, very contrasting.
Right.
Southern Vermont hospital CEOs and boards, yeah.
You may not know the answer to this, but I guess I'm just throwing it out there because I'm thinking about it. So there are certain hospitals that we know are heavily dependent on government payers, more so than some that have commercial payer mix. So obviously, commercial payers negotiate with each individual hospital. So their rates are all over the place based upon their negotiated rate with hospitals. Has there ever been discussion about Vermont Medicaid having different rates for different hospitals and maybe supporting a little bit more by upping reimbursements to hospitals who have, are more reliant upon Medicaid,
Right.
and then maybe scaling back on the hospitals that have the better payer mixes?
I'm not sure if there aren't already kind of adjustments based on that. I don't know enough about how their rate setting works, but I do know that we do have some, for example, Medicare dependent hospitals or critical access hospitals that get additional, right? Like, so our critical access hospitals get cost plus reimbursement, which means Medicare will cover all of their costs plus 1%.
So that's Medicare.
That's Medicare, but Medicaid, I don't know off the top of my head, but that's, you can have them in and ask, or we could.
You're allowed to even do that.
The other hospitals that it came from would not be happy.
Well,
Brian?
So just back to the slide, you were saying that there's some hospitals on corrective action plans or something, performance improvement plans. Sorry, because I feel like a corrective action plan would be more like if they violated Medicare or Medicaid. So I don't want to imply that that's what happened. It's more like a performance improvement plan, like how to spend better maybe or something.
Yeah.
I appreciate that you gave all of the hospitals like some guidelines in advance on March 27th. when are their budgets due? How much time do they have to take this into account and consider it as they build their budget?
That's a very good question. I think, so some of their budgets started building in January.
I feel like people are building your new budget the minute your old one is.
Right.
That's
But they're due July 1st. So there is quite a bit of time to take this into consideration.
Yeah, okay.
Yeah.
All right,
Couple
thanks.
questions. Is there a discussion at the board whether or not net patient revenue growth is still the best way to look at budgets?
It's really hard to think about different mechanisms when it's a facility level payment, right? So I've heard this per capita rate.
That's
per
what I was gonna
capita.
ask, right?
So per capita, I think is interesting when you have a truly integrated and all your patients are in one place and they're not going anywhere else, But I think because we have patient choice and because patients can travel, it's really hard to figure out what a budget should be for a hospital for one patient, right? So I think it's nice in theory, and I think measuring on a per capita basis of healthcare spending overall makes a lot of sense. It becomes much more complicated about who gets that patient when we really have patient choice and we want to preserve patient choice at the end of the day.
Yeah. And do people really choose to go to a hospital that's not their hospital?
Yeah, it depends. I mean, we do see rural bypass. We do see.
What does that mean?
Means people might pass one hospital that's in their backyard to go to another one.
But why is it called rural bypass?
It's a phenomenon that happens more in rural area. I mean, I shouldn't say.
People don't go to the local country hospital, they go to the big city ones?
Yeah.
But if Copley's cheaper, why do people go to
I
UVM?
think, it's a good question. I'm
No
not sure
offense.
everyone knows. There's this price transparency effort, but it's.
Has there been any comparison on per capita spending between UVM and Dartmouth?
I think that's a great, I think there is, we could probably find that.
I just,
That was not even right.
yeah. And not to focus on UVM, but because they are my community hospital, I will. They're the ones that are taking the sickest patients. So sometimes I wonder, like when we compare them to the other 13 hospitals in Vermont, even their own, right? Even
Right.
Porter and CVMC, like what?
Right, so we do have ways of looking at that. So if you look at the CMI adjusted cost for Medicare discharge, that's the one below the administrative and general expenses. That's how much am I spending after adjusting for a case mix index, so how sick my patients are. So there are ways of kind of taking that into consideration. They were still at the 83rd percentile amongst peers. But that's a very good point. So I would expect them to be higher than some of their smaller counterparts.
And are all the peers tertiary
Yes.
centers as well?
The academic, yeah, but I think to your point, and then we also looked, I think, at community hospitals as well. 'Cause that was,
Art, and then Brian, and then.
Yeah, I don't have a question. I was just gonna make a statement on hospitals. In my limited experience, the perception becomes reality in hospitals. There's people in the Rutland area who say never go to Rutland Region.
Right.
And it just, I don't know what it's based on. It's like a hospital, a restaurant. You have one bad experience, you get a bad meal, you get something bad and you don't go back. And we go to Rutland, we've never had a bad experience, have always been treated great. And it's funny how the use of hospitals is almost like a restaurant.
Yeah, yeah.
You have a bad meal, you never go back. You have a bad thing. And,
Point.
my son lives virtually 5 minutes from Rutland Region, and they travel an hour to Porter and Middlebury.
really?
They have their kids. I don't know.
Yeah,
Funny how that is.
good point. Brian, sorry, well, Brian, and then we'll move on.
Yeah, so 2 questions. Once again, like if there's things you can't answer today, we can talk more in the future. But one is, I'm wondering what the impact is of Dartmouth's primary campus, or I don't know if you would call it that, being located in New Hampshire and might play in terms of the Dartmouth network facilities generally being cheaper, because New Hampshire is a different kind of economy. And I just wonder if there's ways that there's efficiencies that they share across state lines. So I'm just wondering, like, and then in that vein, as we learn why some healthcare systems and hospitals are spending less or more efficient, is there any systems in place for like building a culture of, like in social work, we call it like peer supervision, where like the hospital administrators can hang out together and talk about what they do and like learn from each other? Maybe they already do that, but like, just because if there's things that are, if there's practices that are effective, it would be nice to kind of build a culture based on those practices. And if there's practices that are clearly ineffective or expensive and don't, the cost outweighs the benefit, because it's different when the benefit, like having more nursing is, to me, the benefit of that justifies the cost, but like having administrators who make 100 times the lowest paid employee, maybe that benefit of that doesn't outweigh the cost. So like, no offense to administrators, it's not personal, it's structural, but like, but I guess back to the question is there any kind of current mentorship or support network in place, or is that something?
It's a great question. So I think I heard two questions.
Okay.
The first one was on comparing peer groups. And I think it would be nice to have like, even how it's very directional, it's not precise. There's no perfect comparison, right? Every hospital is a little bit different.
People.
And so, like people. And so I think what we're working on now is trying to think about what are the right characteristics to compare to kind of have better ways of, saying what's more or less efficient. But you'll never say like, this is efficient, right? That's really hard to know. So I don't know if Dartmouth has some secret sauce that we don't have in their state or otherwise, or if it's the Learning Collaborative. I think that's a great question for hospitals. I think there are learning collaboratives out there. I don't know the level of engagement or what they're focusing on, but I think that is a wonderful thought. And then I have, yes,
One last question, and then we
What about
are.
one team in relation to Brian?
Yeah, we haven't heard them in a while.
I think you should ask, I think there was talk of learning collaboratives at one point in time. That was part of the hope of that enterprise, is that it would convene hospitals to focus on improving quality and population health. Great. So I just wanted to remind folks about the community engagement. We talked about kind of, why is it so expensive? What's happening? Why is there so much variation? And part of this challenge and the growing costs and growing, premiums, but also hospital sustainability challenges, led you guys to pass this Act 167 work a while ago that directed the Green Mountain Care Board to lead some statewide community engagement. So I wanted to give you all an update and let you know what was happening with that. So we went out into all the communities, wanted to hear from, community providers and Vermonters and our hospitals to hear about what's working and where there may be gaps and opportunities to improve affordability, quality, access, population health. And so that work has begun, and we're kind of in the mix of it right now. So round one meetings happened last October, November, and now we're doing kind of data analysis and synthesis. And then there'll be another round of meetings this summer with recommendations kind of at the end of the summer. And those recommendations will be, for hospitals, for the board, for the legislature, for it'll kind of be kind of a whole list of things that we could think about doing and kind of what some of the challenges are, many of which we already know, access to primary care and mental health, but also challenges discharging patients from hospitals. There are a lot of pressures on hospitals that, might be causing some of these increasing costs that we've been talking about. So I just wanted to end and happy to entertain additional questions, but kind of the key takeaways, healthcare is unaffordable. Our costs are higher and are growing faster than national, as well as some of our New England peers. It impacts Vermonters, businesses, property taxes, really everywhere. Hospital spending represents approximately half of our healthcare spending, so it's $3 billion, probably over $3 billion by now. And these budget increases have consistently outpaced inflation and wage growth, so it makes it really hard for Vermonters to kind of keep up with that. But at the same time, hospitals' financial health is worsening, as you've seen from some of these charts and where we ended in 23. But commercial rate increases are really not a viable mechanism to keep funding these budget increases. So hospital system transformation is going to be really important, and how we do that and thinking creatively if we want to bring down the cost of healthcare.
I find really interesting is that this conversation we're having is very similar to the conversations other committees are having on education. Science.
So parallel.
You know, it's saying rural system, high cost, what's the quality? Yeah, it's very, very, very similar. Brian?
So, I don't know if it's easy to answer this because some hospitals have healthcare, are part of healthcare systems that provide primary care. But I'm curious if there's a way to look at how much we're spending on hospital care versus primary care, even when, like, you know, and you don't have to do this now, but I think that there's evidence out there that spending more, intentionally spending more on primary care has shown improvements of health outcomes in other states. So I'm just curious if there's if there's like a way to compare that, and also ways of working with healthcare systems to figure out how to shift the spending towards primary care more proactively to prevent. You know, that's just one idea. And then the other one, which I don't know if you're gonna get the answer today, is like, what role can AI and precision medicine play in saving money down the road? Because we're on the verge of like this revolution in medicine. And if people have access to precision medicine early in life, we can it may cost money up front to get those procedures, whatever it ends up being, you know, or whatever, because some of it might be like, if we're going to do like genetic therapy on someone, it might be expensive, but it's less expensive than a chronic condition, you know, and especially if we consider someone's like, not that people's lives should equate to productivity in society, but if someone is going to develop like a disease that impairs their ability to function, their own experience is undermined, but then also economically, they need more from others, you know, whereas if like we can use precision medicine and primary care to maximize health and wellness, then it has like ripple effects. So I don't know if that's like going.
So right. No. I think it's a good question. I think, you know, AI and precision medicine and how much, you know, how does it replace or augment your relationship with your primary care provider? I don't know. And like, what is it? It's still very early. Like, we don't know if it's going to have what kind of outcomes for patients, right? But I think to your point about prevention, absolutely. The more we can do to prevent people from getting sick and to help them stay healthy in the first place, the better. And I think we have talked about over the course of many years, we want to see more investment in primary care. I think that's why we had our first healthcare reform model. Whether it yielded more investment in primary care is a separate question, but there are still things we can do, right? We can increase payments, we can fund the blueprint, we can do all kinds of things to expand access to care in community settings. So I think there's a lot that can still be done. We've made some substantial progress, but clearly we have still a lot of work to do. Yeah.
Yeah, I have two questions that are kind of really opposite each other, but and kind of goes back to something Brian might have hinted at. Does the Green Mountain Care Board, have you thought of hosting a retreat for the CEOs? Having something where you go, sit down, figure out what each other's doing, and maybe set some goal that they can get to together or share info. I mean, I think the time has come to try to.
I think the CEOs get together.
Yeah.
On yachts, no, I'm kidding. Sorry.
Well,
Sorry, that was just
That was inappropriate.
okay.
The other
Small
question
ones.
has to do with hospital boarding, and we have all heard about that. And I'm wondering if the stats of boarding, when the cost started to rise astronomically, compared to the number of boarders we have today. And I wonder if that factors into the rise in costs somehow.
Yeah,
Because I think aren't they uncompensated, the boarders? So we have a bunch of people in there who the hospitals are not getting money for versus maybe in 2017, there weren't many.
Yeah, absolutely.
I mean, I don't know if that.
I don't know what the
factors in.
proportion is, but it certainly has an
Yeah.
effect. So
Just-
we're asking about it in this year. I believe we asked about last.
Something to
year.
consider, I would think.
Yes, absolutely. It is a problem. And it's one of the reasons that there was
Factor into this.
there was a budget request from the administration that went to House Human Services to fund nursing home beds, right? So we need to find a solution.
It would be interesting to have the figure before this precipitous rise in costs, how many boarders there were, if any, in
Right.
hospitals.
Okay.
I don't know if that's good.
This messes me all up. My concern is, okay, number one, I want to know the nuts and bolts of why it's unaffordable here in the state of Vermont. Okay, hospitals is what, 47%? There's other factors. It might be legislative mandates. There's a lot of things, and we've got to address all of that. If we're going to get a handle on this, and if we don't, your education department and this, and you're going to see some poor Vermonters out there that's going to need a lot more health care. So.
Yeah, yeah. And we do need to address all of it. And it's also extremely difficult to address. So we just looked at the prescription drug board or whatever we're calling it, right? I mean, so we know the increase in prescription drug prices is really hurting everyone, right? We know that. It's gonna take a long time to fix it.
But healthcare to other states, why are we the highest?
Oh, yes.
Are we,
Yeah.
is our healthcare that much better?
I would say yes.
I'd like to know, I want to spend our money wisely. I'll learn as I go.
You will. We all will. Any other questions for Elaine? This is very helpful. Thank you very much.
Nice, thanks.
All right.
Amazing day.
I'd say one thing too, it's, all of the Green Mountain Care Board's meetings are public. You can attend the ones that are for your hospital budget review process. So it's easy to stay engaged. They've done a really good job with their website, so it's easy to stay engaged. We are back here tomorrow, 15 minutes after the floor. The floor does happen today at 1 o'clock. So